Oh, perfect. It's saying recording, so we'll see if it downloads after.
Yes, it does say from my end that it is recording. So hopefully we'll be able to actually retrieve the recording afterwards.
Perfect, thank you. Okay, a couple more people to admit.
You are okay. Yeah, luckily. Yeah, thank you.
Okay, well that's good. We've got all the diabetes team online, so that's a good start. Okay, so I think we'll make a start. So if you're not talking, if you don't mind muting, that would be great. So my name's Hannah Syed. I'm the diabetes lead pharmacist, and I'm just going to be facilitating this on behalf of the team today. So really just to welcome you all to Insulin Safety Week, which is running this week, May 17th to the 23rd. So just moving across the slides. So you'll see hopefully on the intranet, we've got lots of exciting things happening today, and the team have been out promoting Insulin Safety Week, wearing shirts, and we've got a quiz, and we have also got some bits on social media. So so please look out for it. Take part of the quiz and get involved. We've got some lovely prizes on offer, including 3-course lunch at the Grand, and a lot of gift vouchers and nice things. So do take part. Okay, just on this slide here, those are just our contact numbers if you need them. So I'm sure everyone's really familiar with the way Microsoft Teams works, but just really to say, if you can mute yourselves when you're not talking, that would be great. Do write down any questions that you've got. We'll have some time for a Q&A at the end, and we are recording this session today. So in terms of an agenda, this is our plan for the next hour, and we'll probably be a little bit shorter than that, appreciating that everyone's having lunch. So I'm welcoming Dr. Deshora first, and then followed by some of my colleagues who will introduce themselves as they go. So without further ado, let's hand over to Dr. Deshora.
Hello, everybody. I hope you can all hear me. Hannah will shake her head if she can. Oh, yes, good. That's what we want to see. So welcome, everybody. So you can see here that I'm going to get more likes, it seems. And if I get more likes, then my diagnosis has to be right. But that could be a recipe for disaster and a start of insulin error. So next slide, please. So how big is the problem of insulin safety? What is the fuss? So National Diabetes Audit has shown, and these are stark figures, 40% of people with type 1 diabetes and 37% of people with type 2 diabetes treated with insulin had an insulin error when they were in the hospital. So nearly half of the people. And 1 in 15 insulin infusion were inappropriate, nearly 6%, because we don't want people to be on unnecessary insulin infusion, because that can give rise to hypoglycemia and errors. And 1 in 14 lasted for at least a week, 7%. I don't know which hospital it was, certainly not ours, should only be used when necessary. And 25 people with type 1 diabetes experienced hospital-acquired diabetic ketoacidosis. And 1 in 5, nearly 18%, had a hypo when they were admitted in the hospital, and we should have been able to predict and avoid. So these are the figures. This is why we are talking about, and thanks Hannah for coordinating this and raising the profile for insulin errors and doing the right thing. Next slide, please. So of course, as I said, can't be our hospital, but was I right? So are we different at Conquest in terms of insulin error? And this is how much is the problem in, let's say, Conquest Hospital as compared to the mean for England. We are a little bit better, but over the years from 2010 to 2019, we have considerably improved from 35% to now just 15%, but we need to do better. Next slide, please. And are our people having severe hypos? Again, compared to national mean, at the last count in 2019, we are a bit better, but still considerable number of people get severe hypo. So we call it severe when somebody else had to help the person. And usually the glucose level is less than 3 millimole per liter. Next slide, please. So what about Eastbourne? Are they any better? And you can see again that the problems are similar, and we still have insulin error, although to some extent better than national mean, but this year was a little bit higher in 2019, which is when the count has ended. Next slide, please. And what about hypos in Eastbourne? So again, we continue to have the problem of severe hypo as well. So you got the theme now. So East Sussex Hospital, both hospitals still have some problems. We might be a bit better in some years compared to national mean for England, but the problem is not going to go away. And with new doctors joining every year, we need to remind ourselves. Next slide, please. And here is my story, because Grand Round is about a case. So I'll share my memory of a case with you, and then we'll go forward after that. So I still remember this person distinctly, who we saw in AAU, and he was quite unwell, not eating and drinking, and therefore his insulin was withheld, and he was on insulin infusion, nothing by mouth protocol. After a day or two, we realized that the person had gone to bed ward, and a series of events that had happened ultimately led to his death. So what actually happened? So when the case went to the coroner's court and all the details were reviewed, we found that in AAU, he was previously on nearly 80 units of insulin, and the nurses kept on going to the junior doctors to prescribe insulin. And in the end, one of the junior doctors probably got under pressure and prescribed the insulin as was the usual insulin, without realizing that the person wasn't eating as much and therefore did not need the same dose of insulin. So he was prescribed some 80 units of insulin throughout the day in split doses. The nurses then handed over the case to, I think it was bed ward that time, and did actually say in the handover that we have given the insulin, but because we don't want to lose the bed, we are transferring the patient, but make sure he gets his oral intake or food. So in bed ward, again, there was a cardiac arrest. So the nurses went to the cardiac arrest. This is real life, guys. And therefore, nurses were aware that this person has had insulin and should have food, but they delegated the responsibility to healthcare assistant. And the healthcare assistant was also very careful and made sure that the sandwich was available for the person. But because the cardiac arrest team needed help, he also had to leave and join the team. In this melee, actually, by the time they were over with their acute incident and they came back, the person was already having hypo. They gave glucose levels. They gave glucose infusion. The glucose levels got a bit better, but then the person had long-term damage and ultimately died after a few days. So in the coroner's court, when we were asked for expert witness and advice, the coroner was scathing in terms of what educational input we should put for the juniors and the specialist nurses and the nurses in general in the hospital, so that people get insulin and food when insulin is injected in the appropriate time to avoid these incidents of severe hypoglycemia or any unnecessary death. So that's the story with which we are starting. And as the program unfolds, you will find that there are ways and means in which we can try and give insulin in such a way so that it is for the help to the person and not a harm to the person. And next speaker, please.
So thank you, Dr. Deshora. We'll now introduce Fiona.
Hello, I'm Fiona. I'm one of the diabetes and patient specialist nurses, and I'm going to talk about right insulin. So there are three species of insulin. You have analog, you've got human, and you've got animal. The animal insulin was the original insulin first produced, which was made from beef. Unfortunately, it caused a lot of problems due to it being foreign body. So they used porcine insulin, which is still being used today. There are some type 1 diabetics that still use this, which is their choice. But we generally try and encourage people to switch to either the analog or human alternative. Next slide, please. As you can see, there are lots of different types of insulin. The green coloured insulin are the short and rapid acting. The blue reflect the intermediate and long acting. Then we have the red, which are the mixed. So we've got mixes. That basically means, for example, with the Novamix 30, that the 30 has 30% fast acting and 70% intermediate. With the Humalog mix, that will be 25% fast. And with the Humalog mix 50, that will be 50% of the fast acting. The green coloured are the ultra long acting insulins. Next slide, please, Hannah. This slide just reflects all the different pens, or some of the different pens that we get. There are three main companies that do the insulins, and that's Sanofi, Lilly, and Novo Nordisk. Often the Sanofi products, the device is Solo Star. With Lilly, it's Quick Pen. With Novo Nordisk, it's usually Flex Pen, but sometimes they can be different. But those are the usual devices that we see in the hospital. Next slide, please, Hannah. So as we can see, this is our normal insulin profile. We naturally have our sort of basal insulin running in the background, and whenever we have our main meals, we get a surge of the bolus insulin that helps to keep the insulin levels nice and regulated. So usually when there is no insulin or insufficient insulin being produced, that is when we need external insulin being added in. Next slide, please, Hannah. So the first insulin that we're going to look at is the rapid acting analogues. So we can see from here that they are soluble, they're clear, they usually start working between 10 to 20 minutes. Peak is between 1 to 3 hours, but usually 2 hours, and they last up to 4 hours. The onset is very rapid, so they're really useful for pre-meal insulin. So that's why these are chosen. Next slide, please, Hannah. Then we have our short-acting insulins. So you can see that Actrapid is on here. And I know that a lot of doctors sometimes use actrapid as a sort of stat dose for patients that have high CBG readings. Unfortunately, due to the duration of being up to 8 hours, it's not something that we advocate. So we would normally recommend NovaRapid being used for a stat dose if it's required. So with the short-acting insulins, it's again soluble, clear. Onset is slightly longer, it takes 30 minutes, and normally peaks between 2 to 4 hours, but the duration of action is up to 8 hours. Next slide, please, Hannah. Then we go on to our intermediate acting insulins. These sort of have a sort of crystalline suspension, so they have a cloudy appearance. So they often, well, not often, they always need resuspending when they're being used, which is usually a sort of good shake back and forth to disperse the cloudiness. Their onset is usually about an hour and a half. Peak is between 4 to 12 hours, and the duration of action can be up to 24 hours. So these are analog insulins, and analog insulins are generally designed to mimic much more closely the physiological profile of naturally occurring human insulin. So yeah, thanks, Hannah. Long-acting insulin analogues. So these are insulins that have a much longer profile. For example, glargine, which we know as Lantus, or Toujeo, or Basaglar. Toujeo has a much longer profile, but generally these would work for about 20 to 24 hours. Detamir is also, we know that is Levemir insulin. Next slide, please, Hannah. So with the ultra long-acting insulins, these are really useful, especially for some of our type 1 diabetics, because they have a much longer profile. So as I say, Toujeo can actually last up to 36 hours, Tresiba can last up to 42 hours. I mean, obviously, we don't tell the patients that. We say that they last up to 24 hours so that they get into the good process of giving it every day. But they do allow for a little overlap if people have forgotten or are late taking it. So these are very, very useful insulins, but we do need to take into consideration renal function, because it may be in the system for longer if the renal function is not so good. Next slide, please, Anna. And last, we're looking at the premixed insulin. So human insulin is Humulin M3. And as mentioned earlier, these have a combination of short and intermediate acting insulins. Again, they have a cloudy appearance, so they need that resuspending. Onset is 30 minutes, peak is 2 to 12 hours, and duration of action is up to about 24 hours generally. Even though it's 24 hours, these insulins can be used twice a day if needed. So probably about 60% of patients requiring insulin will use premixed insulins, and the majority of those will generally be on the 30-70 mix. The benefits of using the premixed insulin is that they don't need to mix two different types of insulin. However, patients do need to be eating regularly, and almost need to have a sort of very set routine with this type of insulin. Next slide, please, Hannah. And next we have the pre-mixed analog combinations. So that's NovaMix 30, Humalog Mix 25, or Mix 50. So this is pre-mixed combination of rapid acting and intermediate acting insulin. Again, these are cloudy, so need that resuspension. And the onset is 10 to 20 minutes, peak is 1 to 12, and again, the duration of action is up to 24 hours. I just want to say, often we see on the discharge summary sheets that if patients on a humalog mix, that often it comes up as Humulin I. I think it's because on the drop down it comes up sooner. So it's just something to be aware of when you're looking at the insulins for the discharge summary, just to make sure that it actually matches what the patient is on. Next slide, please, Hannah. So last but not least, we're just looking at the different insulin regimes. So a lot of patients will be on a once daily, they'll be on a sort of basal insulin, which is usually in combination with oral anti-diabetic medications, or also some will be on injectables such as semaglutide, either weekly or daily, depending on which GLP-1 they're on. Some patients will be on twice daily, which will be a mixture of short, rapid, or intermediate acting insulins. As mentioned before, this is most common and really suits those with a very rigid kind of lifestyle. And obviously, most type 1 patients will be on the 4 times daily regime, your basal bolus. And that does allow greater flexibility and usually gives that better bit of control. But to be honest, the best regime is generally the one that the patient will actually agree to take. So it's often about having that discussion with them about which regime they are willing and happy to take in the long run. Thank you.
Thanks, Fiona. That was really interesting, just as a whistle-stop tour. And I think, just emphasising that point that Fiona made around discharges and making sure that, Novo Rapid is not Novo Mix, Humalog is not Humulin. Very easy to do. So definitely really important that we take care when we're selecting those. So now I'd like to welcome the away.
Oh, hello. Good afternoon. My name is Lee Wai. I'm one of the. Oh, come on. Sorry.
Lee, I'm just going to change your slide. Ready? There we go.
Yes. Hello. I'm going to talk to you about the right timing of insulin administration. So yeah, since I started working as a DSN, there has been various incidents that involve wrong timing of insulin administration. I have some some stories later of of this incident. So right timing is as important as right dose of insulin, right patient, so as important as anything else. So as you can see here, there's different types of insulin. So the rapid acting insulin, such as Apidra, Humalog, Novarapid, and Fiasp, should be given 15 minutes before meal. And normally they're given 3 times a day with meals. So that's very important to remember. So they should be given with meals. If the patient, for example, is not eating reliably, and you wanted to make sure that it's given with meals, so we sometimes or we advise nurses to make sure that the patient has eaten and then administer this type of insulin immediately after the patient have eaten, just to really make sure that that is given with food. So the next type of insulin are the long-acting insulin. So we've got here, the most common ones, the Lantus, Levemir, and these ultra long-acting as well, Tresiba, Toujeo, and Abazaglar. So these type of insulin are administered once a day. And I'll just mention about Levemir, because sometimes with Levemir it doesn't cover the whole 24-hour period. So you would notice that patients are being prescribed with Levemir twice a day. So yeah, that can happen. This should be it's with the ultra long acting insulin, and patients who are going to be under district nurses, we try to put them on the ultra ultra long acting insulin because of better flexibility. So if, for example, if the nurses are, running late, giving the insulin, it's not going to make, a lot of difference. But with Lantus, for example, or Levemir, so we advise, that it should be given like, same time every day. Also with the Lantus or Levemir, for example, if the patient are able to administer their insulin, it's better that they have it at nighttime or with their evening meal, so that if we need to follow up the patient and we wanted to titrate their long-acting insulin, the morning reading shows us the reflection of, the dose or of the CBG reading in the morning tells us if the patient requires further titration or if they are in the right dose of insulin. Oh, sorry, Hannah.
Yeah, someone's
Okay,
just taking control of my slides. I'm just going to
sorry.
take control.
Sorry.
Just do that. Okay, sorry, someone keeps taking control. Take back control. Okay, I've got control back. Just accidentally click the button. Sorry guys, we just need to go to where we were. You were on right time, weren't you?
Yes.
What?
Okay. So with the long-acting insulin, if they should be given. They should be given. They should be given for type 1 diabetic, because it's considered as their life-saving. So if they're not eating and drinking, they still should have their long-acting insulin. Otherwise, they will, develop, complications such as DKA, and it's very dangerous to omit long-acting insulin for type 1 diabetic. If, for example, the patient, you're concerned that he's not eating as usual, what can be done is reduce the dose to prevent hypoglycemia, and just regular monitoring. And of course, refer to us if you have any concerns. Next one is, short-acting insulin. So this short-acting insulin, such as Humulin S, Actrapid, Insuman Rapid, should be given before meals, and usually 3 times a day with meals as well. Similar to the rapid acting insulin, but we don't commonly use this short acting insulin. Next one is the intermediate insulin, sorry, such as Humulin I, Insulatard, and Insuman Basal. So this can be given once or twice daily, and so yeah, it can be you don't necessarily need to, but this is to give it with food, as because of their profile. Last one is the sorry, I couldn't see properly, Insuman COM15. So this is the combination of rapid acting and then intermediate acting insulin. So this should be given with food because of the rapid acting insulin that is in combination with the intermediate acting. So this type of insulin, as well as Novomix 30, which is mostly common, they should be prescribed for people who are eating regularly, because if it's given to a patient who is not eating reliably and regularly, then it can cause hypoglycemia, just in case they decided not to eat that particular meal. So some of the some of the incidents that I have encountered as a DSN was like one of the most common one is administration of Novorapid at 2 o'clock in the morning. You know, when when the staff checks the patient CBG and they find that it's like 22 millimoles per liter. So there's the temptation to do something about that high blood sugar. So uh, Novorapid is prescribed and given. However, because it wasn't given with food, so the risk of patient developing hypoglycemia before breakfast, is high. So yeah, make sure that when Novorapid is prescribed, to remind ourselves that it should be given with food. Second incident is administration of Novomix to a patient who's not eating reliably, and some and confused. There was this patient who developed hypoglycemia because he was on Novomix 30 twice a day, but because he was very ill, so yeah, he developed hypoglycemia. Also, in the assessment unit, there was an incident where a type 1 diabetic patient has almost developed DKA because the long-acting insulin has been omitted. The patient came in very confused, and she was refusing to eat. And luckily, she was seen and reviewed that afternoon. So she was given a long-acting insulin, and that sort of prevented her from developing DKA. And next incident is giving of the Novorapid, 2 injections of Novorapid within a span of 2 hours. So what Fee has discussed before about duration of action of insulin is good to know. It's good to be familiarized with the duration of action, because with Novorapid, for example, it's the duration is for 4 hours. So if you give Novorapid within 2 hours, a patient will likely to develop hypoglycemia, because you haven't given enough we haven't given enough time for the Novorapid to do its job before giving the second injection. So yeah, ideally wait for 4 hours and then consider another start dose of Novorapid if needed. And also administration of Novorapid like in an hour after meal. So yeah, if we don't give the Novorapid immediately after meal, there is also a risk of hypoglycemia. Or another is administration of Novorapid too early, before giving that patient his or her meal. Next slide, please. So right device. You probably have noticed that on the drug chart, there's an area for the prescriber to fill out that says device. So there's various device of insulin that are available. For example, in new Novorapid, so it comes in as a 10 ml vial or 3 ml cartridge, as a flex pen or a flex touch. Fiasp as a cartridge as well, flex touch, and a pre-filled pen. So this in the past, the insulin, their concentration is 100 units per ml. So sometimes this is if, for example, the clinician has forgot to write down what kind of device the patient requires, so it doesn't make a lot of difference. However, we have now got ultra long acting insulin such as Tresiba and Toujeo, where the concentration is higher. So for Tresiba, for example, it comes in as 100 units per ml and 200 units per ml. So it's important that we prescribe the right device for the patient, because it means that if the patient, for example, is injecting large amount of insulin, let's say like 100 units of Tresiba per day, and that patient was prescribed with 100 units per ml device pen. So it means that he's giving himself like a larger volume of insulin, because the concentration is different. So yeah, that's one key message about making sure that we're prescribing the right device for the patient. And another one incident, for example, that happened recently. It was regarding an insulin syringe. So please bear in mind that the insulin syringe are used to get insulin from the vial. So we don't extract insulin from the cartridges or from the pre-filled pens. And also bear in mind that each line on the insulin syringe represents 1 unit of insulin. So please, if you're not sure, really double check with your senior colleague that you're using the right syringe, because there are different syringe available in the hospital. So really make sure that you got the right one. So this particular patient was given instead of having 4 units of Novorapid, he was given 40 units of Novorapid. It's because the insulin syringe was used, and probably because of inexperience, that's why it resulted to this mistake. So if possible, if you can get hold of disposable insulin pens for the patient, that will be a better way of managing hyperglycemia or stat doses of Novorapid or Fiasp. And the last incident that I would like to share with you regarding right device is regarding Inolet, so Insulatard and Inolet. So there's this particular patient who has been having, he was prescribed in the hospital with Insulatard, and then the patient was discharged. The only time that we found out that he was using the wrong insulin is because one of the community nurses has noticed that it's not actually Insulatard but Levemir. So yes, so this one here, I don't know if you can see my cursor, but the Inolet device for Levemir and for Insulatard are very similar, except that for Levemir, I think the injection button is colored green. So really make sure that the vial inside the device, you have to make sure that it's the right insulin. So thank you so much.
Hi everyone, my name's Beth. I'm diabetes inpatient specialist nurse at Conquest, and I'll be talking about the right dose and right route. So if we start with the first slide. So to ensure that the patient receives the correct dose, clear prescribing is essential, and therefore we would never recommend using abbreviations such as U or IU. And also ensure that the prescription is signed and dated on the correct page. So we also recommend that we split doses over 50 units into 2 or more injections. So unless the patient is using a higher strength of insulin such as Toujeo 30 units per mil, or Degludec 20 units per mil. Next slide, please. So right dose. So whilst the patient is in hospital, their doses of insulin may need adjustment. So holistically, we'd assess the patient, we'd ask what's brought them into hospital. Have they got an infection that's pushing up the sugars? Are they eating and drinking? So anything that can contribute to their blood sugars. So has that been adjusted, their dose? So if a patient has hypoglycemia or hyperglycemia, have the doses been reviewed? So we normally recommend a 10% increase or decrease for hypos or hypers. If you're not sure, please refer to the diabetes team. If the patient is a new presentation of diabetes, then we normally we'll have this formula here to calculate how much insulin to start patients on. So if you are wanting to put a patient on just a basal insulin alone, then we would look at their body weight and times it by 0.2, and that will give them a dose for basal insulin. If the patient is needing basal bolus, we would do the body weight times 0.5. Bearing in mind patients might be naive to insulin, or if they have some renal impairment, then we might want to decrease it to 0.3. So we talk about total daily doses of insulin. So the basal, so the body weight times 0.3, and then 50% of that would be for their basal insulin. And then the remainder is divided into breakfast, lunches, and dinner doses. And then stat doses. I think Fee's already mentioned about the Actrapid, but we'd also just lightly touch on the fact whether it's clinically needed. Some patients may require stat doses, and then other times we've seen some inappropriate stat doses. So it all depends on the patient, their presentation, and what's going on with that particular patient. Next slide, please. Oh, going really quick.
Give me two. Someone's just taken control of the slide, so
That's
we have
okay.
You were that one. There we go.
That's the one. Yeah. So I think again this might have already been covered slightly, but it's just again to remind you when we're dosing the insulin that there are some newer insulins available now that the strengths are different. So normally the normal standard would be 100 units per mil pens, but on the market now there are some insulin pens that are 200 units per mil and 300 units per mil. So again, when prescribing, just to make sure that the correct pen has been prescribed. So the higher concentration per mil just allows for some better absorption for those patients that are on higher doses. And next slide, please. So for the right route, we have subcutaneous or intravenous. So again, next slide, please, Hannah. So with subcut insulin, we always recommend to the patients to rotate their sites very regularly. Also for optimum control. So we want patients to avoid developing these lumps here, which are lipohypertrophy. So over time, injecting into the same spot day after day can cause these fatty lumps. Unpleasant to look at and maybe uncomfortable for the patient, but also will affect the rate of which the insulin is absorbed, so that it can lead to erratic blood sugars. So also again with the subcut route, we just advise to use the appropriate needles. So they have safety needles if staff are administering the insulin, or if patients are injecting on the ward, they should be assessed whether they are able to and given the correct needles. Again, do not drop insulin from a cartridge or disposable pen. Avoid intramuscular injections and check the CBGs regularly. Next slide, please. So I think the top of that might be cut off unless it's just my computer. So we have 6 protocols in the hospital to match different clinical presentations. So we just want to ensure that the patient is on the correct protocol. So DKA is the orange and white protocol. I think most members of staff will have seen this by now at some point. So to be eligible for this criteria, they need to have D, which stands for diabetes. So they're known to have diabetes, or they're presenting with a new case of diabetes. And the pH, so the below 7.3, meaning they're acidotic. So it's the A, and ketones more than 3. So HHS, so they obviously have to have marked hypoglycemia of more than 30 millimoles per litre, and the osmolality above 320. So for patients who've come in with MI, they don't necessarily have to have diabetes. So anyone that's presented with MI and their blood sugars are more than 11 can go on the ACS protocol, and that is the yellow sheet. And then the green one, nil by mouth, and this can be used in all patients again preoperatively if they're nil by mouth and have CBGs persistently above 14 millimoles per litre. And then for steroids in pregnancy, it's a white and purple protocol, and this is for all women with diabetes receiving steroids and their CBGs have gone above 7.8 millimoles per litre. And the Labour one is for patients with gestational diabetes, type 1 or type 2, and the CBGs are going above 7 on more than 2 occasions. Next slide, please, Hannah. Thank you. So more frequently now, you may come across patients who are on insulin pumps. So these pumps are a continuous subcutaneous insulin infusion, which makes use of an external pump that delivers insulin continuously from a refillable storage reservoir by means of a subcut placed cannula. So patients with insulin pumps will be type 1. So type 1 patients can be on insulin pump therapy, if they're suitable. So the pump delivers insulin continuously by means of a subcut cannula, as I've already said, but the pumps only hold rapid insulin. So these patients do not require a long-acting insulin in the background. And this is because the pump will deliver rapid-acting insulin every few minutes according to the patient's insulin requirements, which is set up on a handheld device. And the pump is sort of the closest thing to mimic the pancreas, the delivery of insulin at this time. So when the patient eats, they can bolus some extra insulin to cover that meal. Next slide, please, Hannah. So the different pumps you might see is we have the patch pump, which is the Omnipod, which is probably the most likely one you'll see. So that is changed every 3 days, sometimes sooner. And the Medtronic and the AccuCheck, they're tubed, so they have a wire to attach the cannula. Just to be aware of those different devices. Next slide, please. So the advantages of having a pump, patients can have better control and more flexibility, and it ensures that they don't have to rely on injecting, so unless they have to because of pump failure. But then there's also disadvantages that they are reliant on real-time insulin delivery, site saturation, and if that pump comes off, they can be at risk of DKA because they'll have no insulin in the background because they're not on a basal insulin. So there's always technical failures and difficulties as a risk of being on a pump. Next slide, please. So if you see a patient that's admitted with a pump, always refer them to the diabetes team. Assess whether they are able to use that pump, and if there's any concerns of them using it, there's a guideline on the Extranet which asks a couple of questions to determine whether they're okay to carry on using that pump. If they're not able to use that pump, then we'd need to detach that pump, take it off, and we need to convert them onto either IV insulin or multiple daily injections. Again, refer to the diabetes team for help with that. Also, just say that if they are managing their pump successfully, they still need to have the insulin prescribed on page 4. So it would be a case of writing them up for either Nova Rapid, Humalog, or Fiasp, but it will come in a vial, and the patient draws it up with their own pump kit. And I think that's next slide. And of course, make sure it's the right patient. Very essential. I think if we click further, it will give some more. Yep, so check and confirm correct patient details before administering any medication, name, date of birth, hospital number, and allergies, check their wristband against the prescription, blah, blah, blah. And then always assess the patient's ability to self-administer insulin daily. If there's any concerns over their technique and they might need some more education, again, refer for the diabetes nurses to come and have a look. Many thanks.
Thanks, Beth. So that brings us on to any questions. So I don't think we've had anything that's come up, but if anyone wants to unmute, now's your opportunity to ask the team any questions you might have. So whilst we're maybe thinking about any questions, we do have a couple that have come in before. So I think we'll just address these ones in the space of time. And if not, then it gives some opportunity for questions to come in. So team, thinking about this one, so how would I refer a patient into the diabetes team?
So ideally, well, it needs to be done on their eSearcher page online. So via eSearcher, there'll be a drop-down box for the referral. So we don't take telephone referrals. We need that time paper trace. That's the word I'm looking for. So yeah, please do it online. Thank you.
Perfect. And the next question that came in was how much stat Nova Rapid to give? Don't know who wants to take that one. Is Fiona talking but not talking and muted?
The first question you need to ask is, as Beth said, is do they actually need a stat dose of Nova Rapid? If they do, then as Lee said, can we give it in time with a meal so that there's no risk of hypo? And in regards to how much, it's quite tricky. It really depends on what their CPG level is at the time, and what we're trying to get down to. So often the 1 unit, if you go by 1 unit, will reduce by 3. That's probably a safe place to start. So 1 unit will reduce their blood sugar by 3. Then you could always work it out from there. But we would always err on the side of caution than giving too much Nova Rapid. If anyone else wants to comment, then please do.
Yes, so we would also, like Bea said, would aim to bring them down to 10 millimoles, just to be on the safe side. Because if they're not used to insulin and they're insulin naive, then aiming for 10 is going to hopefully avoid hypo.
Perfect, thank you. And we've got another question that's come in from on the side. This one is around, is dapagliflozin used in ESHT? So yes, it is. We use it for type 2 diabetes, but it's also got a license for type 1, but that would come under the specialist team. Anyone want to add anything around that? Or I don't know if there's some background behind that question. If you want to unmute, by all means, let us know, or if that's answered your question.
Can I just add, Hannah?
Oh yes, Erwin's here. Thank you, Erwin, for joining us.
Can I just add about the dapagliflozin? I think we just need to be careful about using that in acute patients, of course, because there's been linked to DKA. So I think it's important that if a patient is admitted and well and they're on dapagliflozin prior to admission, that we need to stop that. And this pertains to surgery as well. If you have a patient going for surgery, it is advisable that dapagliflozin is stopped in preparation for the surgery and only restarted after the patient is at home and well. And I think this is also related to the need for blood ketone monitoring for patients on SGLT2, not just dapagliflozin. If they're coming in unwell, because the DKA, it might have been mentioned already a while ago, but the patients on SGLT2 admitted with DKA are normally euglycemic, meaning their blood glucose are not of concern, and yet they could present with very high ketones, blood ketones that is, as well as severe acidemia. So we just need to be careful. There's a place for the therapy, but there's a need to be caution involved in using that in acutely ill patients.
Thank you,
Thank you.
Owen. That was the question was for me because it's just something that came up in looking after heart failure patients that
Okay.
diabetic as well. So thank you very much.
No worries. In that case, heart failure is a different subject altogether, of course. I think there's more evidence of the possible use, or not possible, of the use of SGLT2, especially dapagliflozin. There's more evidence coming out in terms of the management of heart failure. So there is, as I said, a place for therapy or use of SGLT2. But as I said, in acutely ill patients, we have to be very careful.
And Owen, just to add to that, we are in terms of the license for heart failure, it is going through at the moment. It's going through our area prescribing committee with Andrew Marshall. So it will be coming to formulary. It's got a TA. So yeah, just watch this space. Diabetes and cardio are working closely together on that indication.
Excellent. Thanks, Anna.
And when it is used for heart failure, you don't even have to have diabetes.
Yeah, that is another. Yeah.
Okay, I don't think I've seen any more questions come in. Obviously, a really good guide is the ABCD guidelines on SGLT2 inhibitors that Dr. Shore has referenced in the chat. I think we've got 3 minutes left. So should we just, actually the last question is quite useful. So where would we find the DKA protocol? I know Bess talks about the different colors, but where are we going to find that one?
Should be on the wall.
Yeah.
There we go.
Yeah,
If not,
there will be.
CCU have it in AMU if you haven't got one on your wall, but it should be on the walls.
Yes, there'll be paper copies in the wards, of course. And if the staff are running out or running short of them, there's a code at the bottom of the page of the actual printed guideline. So you can ask the ward clerk to order it. But the guideline, if you just want to view it, is available on the extranet as well. It's in the process of being updated at the moment, but I don't think there's going to be any change to the prescription itself. So both electronically and printed should be available out there.
Perfect. Should we've not talked about steroids. I don't know if you can do it in 2 minutes.
Yeah, I'll answer. Yeah. For patients on steroids, if there's no contraindication to using gliclazide, if the renal function is fine, then yeah, gliclazide is a good start. Depending on their weight, you probably would like to start them on 40 milligrams, if not then 80 milligrams. However, if the patient requires insulin, we would go for either insulatard or Humulin I for patients on steroids.
In the morning only, of course, yeah?
In the morning only, yeah.
And just why wouldn't we go for Lantus?
Oh, because of the profile of Lantus, it's flat. So because with steroids, the elevation of blood sugar starts at around lunchtime and then evening and then nighttime. So with insulatard, which it can be prescribed as twice daily, then that can address the elevation of the blood sugar around evening time or starting from lunchtime. So yeah,
I think
with
it is worth. Yeah, it is worth adding that it depends on the steroids, of course. I think prednisolone might just be okay to start once daily. Intermediate acting like Humulin I or insulatard in the morning. But with dexamethasone, as you might see in COVID patients, then I think BD might be the best route. If, of course, you explore the oral options already, which is likely glycoside, either once in the morning only or BD, depending on the steroids used.
Perfect.
And monitoring, make sure that these patients are started on SU and insulin, that they're started on monitoring as well. Very key.
Thank you all.
Thank
Any
you.
thoughts? We are right on the dot, 2 p.m. So thank you everyone for being so organised and keeping to time. We've had 4 different speakers or so on this session, so thank you. And hopefully everyone's found this session useful. Remember to get involved in Insulin Safety Week, the quiz. Make sure you do it, send it in. You know, it's a bit of fun. So hopefully everyone will get something out of the week.
And keep tweeting and keep sharing the video, please.
Thank you.
And thank you everyone for a wonderful job.
Thanks very
Thank
much.
you so much.
Bye.
Thank you.
Bye-bye.
Bye-bye. Bye.